Hello everyone, welcome, and today I'm going to talk about COVID and the emergency department. My name is Dr. Bahati Moseti. I'm an emergency physician, a fellow of the Australasian College for Emergency Medicine. I specialized in emergency medicine in Australia and worked there for a few years as a consultant, for 10 years actually, and just recently moved back to Kenya. I'm currently working at the Nairobi Hospital, where I'm the emergency medicine specialist and trying to grapple with this crisis. So as you know, COVID has really hit us really bad, and we as the frontline emergency department doctors are very, very much affected. I'm just going to go through a few slides and just try and impress upon you or try to inform you of the challenges that we are going through as emergency doctors in this country and all over the world. That slide just shows, right now we know we are experiencing the third wave of COVID. As you can see, the numbers of the first wave were not as much as now. Look at the second wave, we are doing about 800 and something infections per day, and now the third wave is still on the up incline, and we are about 1,200 cases a day. Yesterday actually it was 20-something% positivity rate. So we are really stretched. If you look at that slide, it shows the cases in Africa, and Kenya, I think we are ranked at 10th in Africa. And that just shows the burden of this disease and our facilities, the much we are stretched and unable to meet this challenge. But with a few, not really a few, with a lot of government involvement and doctors' involvement and other people, key players, we might be able to meet this challenge and tame it. So with COVID-19, we have a lot of challenges, and with personnel, I'm going to elaborate those challenges a bit later in my talk. Personnel, equipment, the hospital's number of beds, and medications. And I'm not sure if we are really prepared for this crisis. And given that this is the third wave, I'm not sure if we are really mitigated for it. I think we are a bit unprepared right now, and because of the increased presentations. I don't think anybody was aware of the surge of patients that was going to happen. Unfortunately, here we are, and we have to rise up and meet the challenge. So which challenges do we have as emergency physicians, emergency department countrywide? Most of you refer to them as accident and emergency. I prefer calling them emergency departments. So we have a challenge of the physical space. We have a challenge of equipment. We have a challenge of personnel. And of course, the patients are challenging. When they're presenting with their comorbidities, their illness itself, it's really challenging. So I'm just going to talk briefly about each and the changes that we have done, changes in our practice, changes in guidelines, changes in hospital structure and department structure, and hopefully we will get a view or an understanding of what we are facing as the emergency department and emergency medicine with COVID. So in the physical space, in the hospital currently where I work, that's the Nairobi Hospital, it was designed not with a pandemic in mind. It was designed with the normal diseases that we have. Nobody thought about negative pressure rooms. Nobody thought about isolation, clean and dirty spaces. And now, here we are with the pandemic, we are grappling with physical space. There's limited space in the department. We are finding it very difficult to designate a dirty and a clean zone, a dirty or a red zone, or a clean or a green zone. Cross-contamination is very, very easy, and imagine a patient who comes without COVID and comes to be seen and is seated next to a patient with COVID who's waiting to be seen. We also have the equipment and the staffing. So equipment, it might not fit. We might not have enough equipment in particular spaces that once you delineate as clean and dirty. So there's equipment sharing and staff sharing between infected and uninfected patients. if you look at that slide, we have tried, and I'm sure most emergency departments have tried this. So that is my emergency department. And you can see that it's not really, we cannot really delineate a clean and a dirty area. If you see, if you look at that, we've tried to sort of divide the department and put some bed sheets or some curtains and the trolleys there to try and delineate it. So that's our dirty designated zone. So in our redesign, we decided to have a look at the department and see what will be easier to divide. And the dirty areas, are they easy, and are they going to prevent patients from crossing over to the clean area? So we had to move our resuscitation room, and unfortunately our resuscitation room was smack bang in the middle of the dirty zone. And so a patient comes in, or a COVID patient comes in who tries to die. Are you going to take him into the resuscitation room, the clean resuscitation room, or are you going to leave him in the dirty room with less equipment? So that's one of the challenges we've had, and I'm sure many departments all across this country are struggling with the same issue. That is our clean zone. So we can see where we see some walk-in patients, and on the right of your screen there is a designated clean zone. But the challenge we have is that patients, of course, spill over. Initially, our dirty zone had a capacity, or has a capacity of about 18 to 20 patients. And we are overrun. Every day we have about 30 patients waiting for beds. So where do we keep these patients? The wards are full. So they have to stay in the department, and they have to come to be moved across to the clean zone. If you see the staff members there, you can see they are not wearing PPE, they are not wearing the gowns and all that. So they are exposed. Patient, if you see one of those rooms there, one of those cubicles, and the next cubicle, there is very flimsy separation, and that will put the next patient at risk. Now, are we going to put money and build COVID departments across the country? Are they going to invest in more money? The government going to give us more money and build new emergency departments strictly for COVID? And then when the pandemic is over, what are we going to do with this? I'm just going to briefly show you some slides of what we did at Nairobi Hospital. And just before I go there, that's another depictor of our clean zone, And you can see we've pushed the equipment out of the cubicles, and that is the same equipment that we have to use for COVID and non-COVID patients. That's an ultrasound machine, and that's an ECG machine. We use it for COVID and non-COVID patients. So cross-contamination, we don't have enough equipment. It's really unsafe. Patients and staff are mixing, no physical barriers. There's increased length of stays in the emergency department, and we are really grappling. And now a hospital like Nairobi Hospital is grappling with these issues. What about the other small county hospitals? What about the small dispensaries where COVID patients coming in? What are they going to do? So we decided, I'm just going to this, I think many of you know where this is. This is my facility. Maybe let me stop referring to it by name. I might be in trouble, but we decided to try and get some patients out. So to do sort of a field triage. So you come into the hospital, we give you quick questions. Do you have respiratory symptoms? And if you do have respiratory symptoms, we see you at the tent outside the hospital. So if you do not have, you come in. But as you know, patients with COVID might not have respiratory symptoms, or a patient might be asymptomatic, so he'll slip into the clean zone. So there are those tents there. We are seeing patients who have COVID-like symptoms, where they'll be seen by a doctor, tried and treated, and probably sent home and not come into the department. But as you know, many patients, and actually I was even seeing this among some, even with our own colleagues, when they got diagnosed with COVID, when COVID came out, everybody thought that you have to go to hospital with COVID, and that mentality still remains the same. So patients in out here will complain and they want to come in. Then we have this problem of a bed block. Just before I go there, we were lucky to have a center that built for us an emergency department for COVID, but unfortunately we don't have enough staff to stock it. So we have a big issue on physical space, what we call bed block, and I'm not sure if many hospitals in this country have had bed block or have experienced this, but where I worked before, we had a lot increased bed block because all the medical facilities were free. So these are hospital-wide issues. So you have the patients stuck in the wards. So we have COVID patients have a long stay. So I think the average hospitalization for a sick COVID patient is about 10 days. So a patient is holding a ward bed for 10 days and there are new patients coming in. So where will these patients stay? These patients will be kept in the emergency department waiting for these beds in the hospital to be clear. What does that mean? Of course, it makes us, the patients have an increased length of stay, limits isolation wards and the beds in the department. Isolation spaces are limited. We have stretched resources and increased turnaround times with patients. And then, of course, we are unable to adhere to the zoned areas that then they become irrelevant. And that's really, really what I think many departments are facing. So you imagine starting the day with, for example, you come into your department, and this is a true scenario. You come to work in the morning and you have a ventilated patient in one of your bays on day 3 waiting for an ICU bed. And then you have 9 patients who've been confirmed COVID positive. They are waiting in patient beds. You have 2 patients, 2 expects because they want to come to your facility. They have been confirmed COVID positive with low saturations and they'll require either non-invasive ventilation or intubation on arrival. And then you have admissions desk in the hospital sending you 2 patients confirmed COVID positive. And then to make matters worse, 2 doctors have called in sick and nursing, you're short of 2 nurses. And that is your day to start with. And then, of course, there'll be patients who'll be walking in, COVID patients. So it's a big mess. It's a big mess everywhere. And I think the government needs to come up with more guidelines or more help, or maybe designate some hospitals as COVID hospitals, maybe open field hospitals. Because with the current infrastructure we have, and if this wave does not go down, we are going to be in a lot of trouble. We have had to change our working methods, and that's clinically. We've had to change some things in emergency medicine because of this COVID pandemic. So I'll start with maybe the way we've changed our work is with triage. We've adopted a rapid triage, sort of a field triage. So where we do a rapid identification and strict isolation of patients. So basically it's a question of ILI, that is influenza-like illness versus other illnesses. Then we segregate these patients. If you have ILI symptoms, you go to a COVID area, and we try and cohort the patients with respiratory and suspect symptoms together. So the downside of this is that unfortunately some patients might be cohorted with COVID patients, and you have no COVID, so potential infection again. There's a very good paper, if those of you interested in academia, there's a good paper by the European Society for Emergency Medicine on this triage and the field triage that some European hospitals adopted during the crisis. We've also had ILCOR, that is the International Liaison Committee on Resuscitation, is our peak emergency body on resuscitation. And they have a website. For those of you interested, you can visit. But ILCOR did a systematic review of evidence examining the risk to rescuers from patients in cardiac arrest with COVID, and they posted this for the public for comments by the 30th of March, and given the feedback from all the emergency associations all over the world, they just changed a few things in resuscitation, which I'll go through. So there's always been talk about chest compressions and CPR having the potential to generate aerosols. And ILCOR looked at this, and lay rescuers are allowed to continue with compressions. And before you get to public access defibrillation, this is in centers where you have, or in countries where you have public defibrillators available. But initially, in summary, chest compressions are very low risk, and people are fast responders to a cardiac arrest are recommended to start CPR. And if you have a defibrillator, you are advised to connect a defibrillator to a patient before you don PPE, because then you can zap them out of any dysrhythmia that they may have. So For those of you, I hope most of you have done BLS and ALS. And remember, in our BLS, before you call for help, you have to listen to if a patient is breathing and put your ear next to his mouth and to see if he's breathing. And that now recommendation has been struck out in these COVID times. So you only have to recognize for look and see if the patient is breathing, not checking for. So check for response, assess for breathing. Do not put your face next to the patient's mouth or nose and then call for help. So that step has been taken out of the BLS. So dispatcher recognition and initiation of CPR. Do not put your face next to the patient or your ear next to the patient's face. And also for the recommendation for people who go to respond to children having an arrest, if you want to, you can still give them rescue breaths, and that recommendation is still on despite the danger, and if you are willing to, you can still give your rescue breath. So another big thing with practice is advanced airway management during cardiac arrests. And there was, of course, the BVM. For those of you who have done ACLS, you use a bag valve mask to give oxygen and rescue breaths and all that. That has been noted to have to cause aerosolizing and spread COVID. So it's been recommended that avoid that step or use it as minimal as possible. The best thing to do is to get an advanced airway in either a supraglottic airway or a tube and blow up the cuff so that you avoid aerosolizing procedures. Actually, intubations and RSIs in COVID has been the RSI procedures have changed slightly. Remember, when you're doing RSI, you will bag after just giving a paralytic. If you're using a paralytic that will take maybe a minute to kick in, you are supposed to be bagging the patient to maintain oxygenation. But there's a recommendation from ILCOR that once you paralyze a patient, do not bag the patient. Just wait, give it time, give the paralytic time to kick in, and then you can attempt your intubation. And the best intubator, the most experienced intubator, should do the intubation to minimize missed intubation and a long time prolonged manipulation of the airway. So there's also giving chest compressions. I'm not sure this is for facilities that will afford that machine, that device there. It's called a Lucas machine, and it's used for giving compressions. So it's recommended. We have that in the facility I work here in Nairobi, and I'm sure some top hospitals in Nairobi have that, but other hospitals all over the country may not have a Lucas machine, but it's recommended. That keeps personnel away from the patient. You're doing a mechanical ventilation, you're using a Lucas machine, and that is less contact with patients. All right, so we've also tried in my facility, we've tried to change our clinical shifts, give doctors longer shifts but lesser days. So they will come in and maybe work for a longer shift and maybe work 3 days a week instead of 5 days to lessen the exposure. And of course, doctors and nurses going into the red zone will be wearing all those helmets, they'll be wearing all those suits. It's really, really uncomfortable. I don't know if any of you have worn this. I find personally, I cannot stay for more than 30 minutes in that suit. And looking at some literature and people in Wuhan, when this thing struck, were staying in these suits all day. So it's really, really stressful on medical personnel. So we are trying to increase clinical shifts, reduce time in the red zone, but reduce total time of doctors and nurses coming to work in these areas. This is from my facility, some challenges we have. So imagine a patient comes into your department and is suspected to have COVID, and you want to admit this patient. Do you take him to the ward? Which ward do you take him to? Do you take him to the normal ward, but you've not had a PCR back? Because I think minimal time for PCR test in this country is still about 12 hours. Let's say 8 hours at the best. So that's when you'll get a test, a PCR test, to confirm that this guy or this patient really has COVID. So the patient is there with you. You are waiting for a test because you have to cohort this patient to the correct ward. We have COVID wards and non-COVID wards. So the patient comes there and stays in your department, and you have to wait for 12 hours. So this is a challenge. The lab is giving you results in 12 hours, so the patient will still stay with you. And does that cause more crowding of COVID patients in the emergency department? So we try to mitigate this in my facility by doing a HRCT, that's a high resolution CT scan of the chest. And with that, we can assess we can see the lung damage. So the patient has symptoms like COVID, has symptoms like COVID, signs like COVID, and a test at least to determine that is COVID. PCR will take long, so we are trying to fast track these patients out from our department by using HRCTs. The challenge is how many hospitals or how many departments across this country have access to HRCT. That's one. And secondly, how many patients will afford a HRCT? So that's another challenge. At least as we are lucky, most patients who are coming to our facility can afford it or have insurance to cover that. So that's a very, very big challenge, because if we cannot segregate the patients from the emergency department before we admit them, we are going to cause a mix of patients in the hospital, in patients, and potentially spread this disease further. So very big challenge. I'll really be happy to hear from you what you are doing in your facilities. We also are trying to bring in new devices, and because we do not want to put all these patients on a ventilator, from oxygen delivery devices. So I'm sure most of you know about this. So breathing aids in COVID-19, we can give oxygen therapy, nasal prongs, oxygen masks, non-rebreather masks, or we can put them on a ventilator. And that was initially when COVID broke out, patients were just being put on ventilators, but that was shown that putting a patient on a ventilator had bad outcomes. So we are trying as much to try and avoid intubating these patients, avoid intubating them, because once you intubate them, they have to go to an ICU, and the beds are limited. The beds are at a premium, ICU beds are at a premium. So we are just exploring a lot of CPAP devices, and unfortunately we don't have a lot of choice or range of these devices here, or very limited. Even in my facility, very limited devices for CPAP. Other devices that we've tried here is high flow nasal prongs, which have the capacity to deliver up to 60 liters per minute. But these are limited. We give them to mainly in hypoxemic patients, and it dries the nose. The machine is expensive. Not many people know how to work it, and it has a potential for aerosolizing. And on that picture on the right, you can see the high flow nasal prong diagram on the third diagram, number 3. Some people have tried hyperbaric oxygenation, but that is beyond our reach here in this country. I'm not sure if I've seen any place use hyperbaric oxygenation. What we have found in my facility to really help us a lot is NIV, non-invasive ventilation, and CPAP. And there's a paper there that was done. There's a research that was done about NIV, and it shows even before COVID, we knew that NIV will prevent intubations, or delay intubations, and potential to prevent intubations. And actually, patients can turn around with just NIV and do not have to be intubated. And actually, 33% of COVID patients requiring ICU beds in Europe, they used NIV. And together with high flow nasal oxygenation, they may be appropriate bridging adjunct in the early part of the disease process, and they may prevent the need for intubation and invasive ventilation. And actually, the patients we are putting on NIV in my facility, in my hospital, are really doing well, and they're just going on NIV and avoiding ICU, avoiding intubations. Another very new thing that we are using, and last week we had a training throughout the country, and we got people from Mombasa, Nakuru, and I think Kisumu, all over, and it's helmet CPAP. Very, very easy device to use, was used a lot in Italy and other countries in Europe to avoid intubation. It's very, very better tolerated than the mask of NIV. So there's a very little amount of dispersion and aerosolization with the helmet ventilation, and it can mitigate an ICU admission. Patients do not have to be intubated because they can really do well on this. Actually, on my way here, just before I came here, I just put a patient on NIV, and by the time I reached here, the patient was saturating at 90-something% on the helmet CPAP, and this is a patient I had considered intubating. So I put her on helmet CPAP, and she's doing better, and actually we are going down on oxygen. So there's a review that was done on helmet CPAP on COVID-19 patients, and the paper there that I've just put for you, for whoever is interested, on the right side of the screen. And that's the way it looks like. That's a form of a helmet CPAP. The ones we have are a simplified version of that, easy to use. Very easy to put on the patient. Patients can tolerate it more easily, and actually has helped us forestall a lot of intubations and get patients better on the road to recovery, lessen admission days. And actually, I dare say that this thing can be used at home. If there's a nurse who can put it, patients don't have to come to hospital. Maybe you can use it at home once we get better use of it. But for now, I recommend only hospital use. For the manpower, for the personnel, we found that we have had increased work burden. We have new tasks with no or minimal training. For example, helmet ventilation, we had to have training on the go. We've had new equipment to use with this disease that we don't know. How many people here can use a ventilator? Very few, only anesthetists and people working in critical areas. How many people can use NIV? Most of the ventilators we have now, I think, can deliver NIV, but many people don't know how to use it. We are working in a new hostile environment that is a danger to ourselves as a providers, as a care providers. And of course, it leads to a lot of demotivation. Staff are getting infected and going home for 2 weeks, 3 weeks. If you get infected, it's 2 weeks off. If you get significant risky exposure, it's 2 weeks off. So we are having less, we have less personnel in the emergency department. We have nurses are off, doctors are off, other people who work in the department are off, sweepers and all that, cleaners are off. So we are working at a very stretched personnel, and there's a lot of demotivation. There's a lot of people are discouraged. So that's another challenge, another big challenge that we have. So what I like to say in summary is that we need a systems approach to managing this COVID-19. We need a lot of support, a lot of government support. And if one department struggles, it has a cascade effect on all other departments. If KNH is struggling, not taking patients, the patients will go to other hospitals. If Nairobi Hospital Mater is struggling, all other departments also will be struggling because they will have a deluge of patients. What we have noticed is delays in labs and lead to delays in one department, leads to delays and delays in definitive disposition of patients will lead to delays in accident and emergency departments, increasing the turnaround time and poor patient outcomes. So I think I've tried in a nutshell to try and inform you about the COVID and emergency department and the problems and the challenges that we've been facing. And if you have any questions, I think KMA has my contacts. I'm happy to answer any questions on a blog or electronically, or if you need my contacts, you can get them through KMA. Thank you very much.